So I'll be discussing the response of tumor after treatment with a focus on how imaging criteria has evolved the era of targeted therapy and immunotherapy. So initially, about 20-25 years ago, the criteria was basically anatomic. Anatomic means the first one that we see here. And that was because we usually resorted to cytotoxic treatment, cytotoxic chemotherapy. So the shrinkage in size was the only criteria that was used. However, with time, with the advent of immunotherapy and targeted therapies, the tumor size might not shrink, but the necrosis within the tumor, the functional level within the tumor decreases. So the size is no more the criteria in all the tumors. So we'll talk about RECIST, we'll talk about the functional criteria CHOI, and we'll talk about PERSIST. So RECIST, a lot of us have been following RECIST. It's basically for solid tumors that are being treated with cytotoxic drugs. So it's only a size-based criteria, does not assess targeted or immunotherapies. So there are four categories basically. Either the tumor response to treatment. Response means 30% decrease in the size of the tumor, and progression is more than 20% increase in the size, the total sum of size of the tumors that we take. And partial responses where there is no progression or partial response. And complete resolution is when there is the tumor is completely gone. So we take 5 lesions, maximum of 5 lesions, and we take maximum of 2 lesions per organ. The diameter should be more than 10 mm. The longest diameter should be more than 10 mm. And we add them up. We add all the lesions. For lymph nodes, the criteria is the short axis should be at least 15 mm. For lesion, more than 10 mm should be size. For lymph nodes, 15 mm. If the tumor fragments over a period, we individually add up the 2 lesions and then we compare with the baseline scan. So this is just an example where we see that the lesion here is smaller in size at baseline, but then on the left we see that the lesion is increased. So there is more than 30% increase in the size of the tumor. So this is progression. Partial response is when the tumor at baseline is larger and it decreases by more than 30%. So that is partial response. There are non-measurable lesions like miliary metastasis. They cannot be measured. Their size is less than 10 mm. So these are non-measurable lesions. We do not consider this in RECIST. Other non-measurable lesions are lymphangitis surrounding the lung malignancy, ascites, bone lesions. We cannot consider this as measurable lesions. However, if the bone lesion has soft tissue component, we do measure the soft tissue component part. Limitation, tumor necrosis is not assessed. Density change is not assessed. Metabolic activity within the tumor is not assessed by RECIST. So what we do is we talk about some chemo. Initially, the traditional chemotherapies included the anti-cancer drugs that eventually led to cell death. Now we've got, usually in GI malignancy, it's either platinum-based or fluoropyridines-based. We've heard the names cisplatin, carboplatin, oxaliplatin, or 5-FU or capecitabine regularly being used in our GI malignancies. Now, over the time, as improvement has come up with targeted and immunotherapies, we look at the mutations in lesion. There are Herceptin mutations, there are EGFR mutations, VEGF mutations. So we come with monoclonal antibodies. And these are all immune checkpoint inhibitors. Immune checkpoint inhibitors is initially tumor cells used to inhibit the response of T cells and B cells. So the production of T cells and B cells used to be less. Now our target is to increase the T and B cells. The response to tumor should be increased. So these drugs help abolish the tumor cells attachment to the T cells and its diminution, its number decrease. So we initially used to deal with tumor, now we deal with the immune system in treatment. Mind the AB and IB means AB is monoclonal antibodies like nivolumab and all the maps that we talked about recently. IBs are the targeted therapies like sunitinib, imatinib that we use. These are a list of all the monoclonal antibodies that we normally use. So what they do is, initially when the tumor used to grow, it used to be progressive disease. When it used to shrink, it used to be partial response. But now the tumors are same in size. However, there is no active tumor cells within the lesion. So we assess this. Necrosis within the lesion can be used if there is a lesion here and the lesion cannot be seen on the subsequent scan, or there is hemorrhage within the lesion. This is still response. However, if you compare the size has not decreased. Again, the lesion, the size, this is a metastatic lesion in liver, peripherally reminiscing, size 6.1 centimeter. Subsequent scan after treatment, size is still 6.3 centimeter, but there is a large necrotic area within, which suggests response because the necrosis has increased. So there are different categories for different parts of the GI malignancy. We'll first talk about the rectal malignancy. We use MR-TRG, that is MR tumor regression grade. So first we have to know the T staging. T1 is the tumor is limited to mucosa, submucosa. T2 is the tumor is limited by muscularized propria, as we can see here. And T3 is the extension of the lesion outside the muscularized propria. T4, A and B, it's into the adjacent structures, whether it's the visceral peritoneum or adjacent structures. In T1 and T2, we do not need neoadjuvant chemo RT. We straight away go for upfront surgery. In T3 and T4, role of CTRT or chemotherapy, radiotherapy, and its subsequent evaluation is done. So this is the grade where MRTRG1 is when there is no tumor at all. We use T2 and diffusion weighted images. We see no restriction at all. MR5, where there is no response at all. So the entire tumor is left. We talk about 2, 3, and 4. 2, there is a dense scar. However, on diffusion restriction, there is no lesion. 3, there is a scar with restriction on diffusion weighted. 4, there is more diffusion restriction. So this is how we see. 1, no lesion. 5, the complete lesion is there. 2 is only there is a scar, no diffusion restriction. 3, there is restriction, less than 50%. 4, there is more than 50%. So this is how we evaluate the rectal malignancy after chemoradiation. So similar example where this is the pre-CTRT and this is the post-CTRT. Pre-CTRT T2 shows a lesion which shows restriction. Post-CTRT there is a dense fibrotic scar. However, on diffusion weighted there is lesion left, which means the response has been inadequate. Similarly, this is the upper patient whereas there is complete response. There is no lesion left on colonoscopy. There is no lesion on T2 weighted image. There is no lesion on the diffusion weighted image. Second patient, there is a lesion after CTRT. There is a lesion left. There is T2, there is intermediate signal intensity, and on diffusion weighted, we see lesion. Now we come to CHOI criteria. It's usually for vascular tumors like GEST. It considers not only size, but also the density within the lesion, and is used after targeted therapies. It has got similar criteria where the only point we need to know is if there is decrease in more than 15% enhancement within the lesion, that is partial response, despite the size being the same. If there is more than 10% increase in size or density, then we call as progressive disease. So this is a GEST, malignant GEST from stomach with peritoneal deposit and hepatic mets. We see a lot of vascularity within. After treatment with imatinib, mesylate, we see that the lesion size is not decreased, but there is a lot of necrosis within the lesion. So according to size criteria, this has not responded. However, if we consider the necrosis, it has responded very well. Similar lesion, malignant GEST, exophytic lesion from stomach, infiltrating into adjacent structures, a lot of cellularity within. After treatment, we see a lot of necrosis, the tumor cells come down. This is again the example of GIST. About HCC, we just discussed about HCC. We use modified RECIST. Modified RECIST evaluates the viable tumor, that is the vascularity arterial enhancement. So these are all the techniques of treatment that we use in HCC, from percutaneous ablations to TACE to TARE to TKIs to monoclonal antibodies. This is again the mRECIST criteria for HCC, where the progression is when there is 20% increase in size or there is a viable lesion left. Whereas partial response is if there is 30% decrease in size or the enhancing lesion is come down. So we divide it into target and non-target lesions on scan. Target lesion has to be well encapsulated, more than 10 centimeter, has to have hyper enhancement within, so there has to be an enhancing nodule within the lesion. Any other lesion is non-target lesion. How do we measure? We measure the enhancing portion only. We do not measure the necrotic portion within the lesion. So suppose this is a scan of HCC that's been treated. We see the lesion is similar in size, however this is all the necrotic non-enhancing portion. So we do not take this measurement. We rather take the enhancing nodule measurements. So the tumor has responded well to treatment. Any patient, this is a patient with HCC on sorafenib. The enhancing portion is completely gone. So this is complete resolution if you evaluate by mRECIST. After TACE again, if it's completely opacified, it's homogeneous, it's complete response. Heterogeneous is incomplete response. Defective response, and if there is no contrast within, this is deficient response. This is one patient, this is another patient. The first patient in non-arterial phase and arterial phase, we see that there is complete opacification of lesion after HCC. So this is good response. However, there is a defective opacification of the lesion after TACE on non-contrast and contrast phase. This is residual tumor within the lesion. We've talked about LIRADS. There are three criteria: non-viable, viable, and equivocal. Now we talk about iRECIST. iRECIST is immune response to immunotherapies. And two concepts are there. One is IUPD, which is initial progression of disease, and ICPD, which is confirmed progression of disease. Any tumor that is being treated with the monoclonal antibodies, the immunotherapies, the programmed death, PD-1, PD-L1 inhibitors. If you look at the tumor, according to RECIST, the green part here is the tumor. The purple part here is the lymphocyte. If it decreases in size, according to RECIST, it's come down. It's a good response. And if the tumor number increases, the green part increases, it's progression. However, with immunotherapy, we see that the size has increased. However, the tumor cells have come down. So just looking at the size criteria, we should not stop the treatment after a follow-up if the patient is on immunotherapy. We wait for a time because the tumor increases. However, with time, the tumor decreases. So this is called pseudoprogression. Pseudoprogression is there is a lot of mast cells and macrophages, T lymphocytes within the tumor in the initial scan. And we wait for another 4 to 8 weeks. So we get a response to treatment. So usually pseudoprogression versus true progression, we look at the density. The density is decreased in the larger lesion on pseudoprogression. The diffusion weighted, so no restriction in diffusion weighted image, PET scan, the SUV value is less. So if we see a liver lesion here in segment 4, this has increased over time after treatment on immunotherapy. This is pseudoprogression. We repeat the scan, and it is further increased. So this is confirmed progression of disease. This is ICPD. However, for example, we got 4 lesions, 2 in liver and 2 in spleen. The total sum of the lesion is 100. With immunotherapy, we do a scan after 1 month. We get a value of 130. The total sum of the lesions is 130. So there is progression, but this is pseudoprogression. So we wait for another 4 to 8 weeks. And we do a second scan, and the lesions come down. The total sum of the lesion is come to 60. So this is immune partial response. The initial progression does not count. So this is the trick with the immunotherapy. There are a lot of complications of immunotherapy, so we'll not talk about that. Now we'll come to persist. Persist is by PET scan. We look at the SUL, that is the standardized optic value against the lean body mass. Again, 30% increase in uptake of the sugar by the lesion is progression. And if there is 30% decrease, then that is partial response. So this is a G junction mass which responds to treatment. The SUV and SUL has come down. So these are the emerging techniques: diffusion, radiomics, liquid biopsy, and dual energy CT that are coming up. And so RECIST does not only differentiate between the solid tumors, but with the advent of newer treatment, we should look at the other newer criteria and not only resort to RECIST while reporting. Thank you.